With that, ladies and gentlemen, I'd like to welcome on our behalf Dr. Jeffrey Dayton. He is a practicing emergency room physician, administering to patients at the trauma center, level 2 trauma center at St. Mary's in Long Beach. Prior to that, Dr. Dayton worked at Little Company of Mary in San Pedro. He has a degree in medicine and a Ph.D. in epidemiology. Jeff is also known as the very active Anita Creedy's husband, and they have kids at St. James and are active members in our parish. So ladies and gentlemen, please join me in a warm welcome for Dr. Jeffrey Dayton.
Thank you. Hope everyone can hear from there. So my name is Jeff Dayton. I'm an ER physician, so that means I work in ER over at Little Company in San Pedro and also St. Mary's. I also trained at Harvey UCLA. Oh, sorry. Is that better? Basically, this is kind of my work environment, and I'm going to be kind of approaching this talk a little bit from Sister Kitty, but also kind of along the same lines that she was talking about. This is essentially, if you've been to ER recently, this is kind of the same pictures that we get. It's crowded, it's busy. A lot of times, though, I have to have conversations with patients and family regarding the end of life issues, what kind of interventions they want or don't want. And kind of what, everything we do has a risk and a benefit to it. So, some of the things we do are not helpful to patients and can cause harm. And it's kind of helpful to understand that. We also kind of speak a different language in the ER. I went through medical school. Basically, the first 2 years, they brainwash you. They basically teach you not to write anymore. So they teach you all this new stuff. You can no longer handwrite after you learn all this stuff. They teach you a whole different language, and then they throw you back out there with patients. And you have to talk to them, and they're basically trying to relay what you've learned and how you are speaking, and you have to talk, in a different language and relate that back to what the basics are. So I'm going to go through what some of the terminology we use and what these things kind of mean and what is involved when we go through. It's basically someone's code status. Do you want to be resuscitated or not resuscitated? Okay. Just wanted to start with a little quote from Albert Einstein, and this is kind of along what Sister Kitty was talking about, that some of the stuff we do is not helpful. We do have a lot of scientific advances. We can do a lot of things. There's a kind of in the United States, a sense that we can save someone's life or bring them back, when in sense, unfortunately, there are a lot of situations we can't do that. Okay, so basically it just says that it has become appallingly obvious that our technology has exceeded our humanity. From Albert Einstein. So basically we'll talk about the code status. First, kind of making sense of what we're talking about. So full code, what does that mean? What do we do in a code? Basically what we're doing is if someone's heart or their lungs stop, what kind of things are we trying to do to restart that? The question kind of coming up is, do you want that to be done if someone's got dementia or terminal cancer, things like that? If you're young and healthy, then most people will say, yeah, I want everything done because I might get back to the state I was in before when this happened. So we see patients that have had heart attacks or things like that sometimes we can resuscitate them and then go back to living their normal life. A lot of times though, fortunately, because of media and TV and stuff like that, I know my wife likes to watch a lot of medical shows, and I'm always kind of rolling my eyes because they bring back people, it seems like 100% of the time if you have a heart attack or you stop breathing or your heart stops in the hospital, that we bring you back, which unfortunately is not really the case. So I'm going to talk about what we call full code, do not resuscitate, meaning essentially not doing stuff. I often have to remind the nurses that I work with that this is actually not, do not treat, okay? So if I say I don't want to be resuscitated, doesn't mean I don't want to be treated. So a lot of individuals say I don't want my heart I don't want chest compressions, I don't want to be intubated, but I do want antibiotics, I want fluids, I want to be comfortable. So those are things we have to kind of keep in mind. Going from, this is kind of a little thing that when I work at Little Company in San Pedro, sometimes I'll admit a patient, and a lot of times, unfortunately, the way the medical system works now, you have a physician, the old style is you have a family physician who knew you for years and knew what you might want or didn't want to talk to you about this. Unfortunately, now with the healthcare system, you have about 15 minutes with the doctor. You might see a different doctor every time you go into the clinic or an office. A lot of times they don't know. So I'll get someone who's in the ER, they're very sick, and the doctor will say, what's their code status? And I'll say, well, you don't know? And they say, no, I've never really talked about that with a patient. I've even talked to oncologists and patients with terminal cancer that oncologists, there's a lot of reasons that we have our own baggage and issues with death too that they don't bring it up or talk about it. So this is kind of stuff I go through step by step. Do you want this or do you not want this? What does this mean? What kind of things are we hoping to accomplish by doing these type of interventions? So first, kind of talking about what we do when we code somebody. It starts out with paramedics. If someone calls 911, people can do this if someone is going through CPR classes, things like that. What we're trying to do is bring someone back basically from a near-death experience. It involves kind of chest compressions. Some people call this CPR. That kind of means is basically compressing someone's chest. We also do things called intubation. We put in breathing tubes, things like that. Defibrillation or shocking someone. You see the TV dramas where they're shocking, yelling clear, all these type of things. What those kind of things are meaning. I'm going to go through this a little bit one at a time. What we're trying to do is essentially trying to bring back the brain. So in a sense, your heart stops, your lungs are not working. So these are things that we do to try to bring back that kind of situation. So there's a picture kind of your heart, your lungs, and your brain. We're going to go through each one here. So essentially first question is someone have a meaningful recovery? So if someone's got dementia or terminal cancer and we bring them back, we're not going to cure the underlying problem. If someone's in their 30s or 40s and they unfortunately have a heart attack and they were active and normal, we have a better chance of bringing them back to where they were if we do the code. So these are some things to keep in the back of your mind. Sometimes we end up coding patients that we know, they're not going to bring them back to anything except for the baseline where they were at. And unfortunately, for a lot of patients in nursing homes, it might not be the most, the best circumstances or situation. Basically when you watch TV shows, it looks like everyone's coming back, and media has all these wonderful stories about people bringing people back to life, which does happen. It's also pretty rare. When they do studies, depending on the situation before, when we do this code and CPR and compressions, we have a success rate of actually having someone discharged from the hospital from around 0 to 15%, kind of depending on what their pre-existing conditions were. So not the greatest. And then, like Sister Kitty was saying, sometimes it's better for us to offer comfort to a patient rather than going through some of these more aggressive measures. Something to keep in mind. And it's also difficult for us. We went to medical school, we went to all the nurses and the doctors, and we went through training basically to try to help somebody, to save a life, to prevent someone from dying. And it's not easy for us to say, unfortunately there's nothing we can do. For us, that saying that someone's death is essentially us admitting defeat is how some of us look at it. That's something that I think as you get longer and longer in my career, it's something that's easier for you to accept that unfortunately this is a part of life, and it is something to keep in the back of your mind. So basically, what do we mean by CPR, cardiopulmonary resuscitation? By trying to bring back the heart and the lungs, like I was talking about. One thing we do is chest compressions. This is basically, we're pushing unforcefully in someone's ribs, trying to get the heart to pump blood to the brain, to the vital organs, in hopes that we're actually, in some sense, trying to get this heart to restart. This is kind of a temporary measure. Sometimes we'll shock the heart later on, try to get it back to beating. Your heart has kind of electrical activity where it starts to, the top part beats, and kind of little electrical wires, in a sense, make the bottom part beat, and that should be doing that normal on a regular basis. Sometimes it doesn't do that at all. And so we're trying to kind of temporize things. So if you were to do anything, this is one of the better things to do because it's been shown that if you do this early on, this can help as far as someone's outcome overall. A lot of times, unfortunately, paramedics will arrive on the scene and someone's been lying there, no one's done compressions for a long time or doesn't know how to do that. So one thing to take away from this is take a first aid class. It's fairly easy to do this. The other thing we do is what we call defibrillation. We're basically trying to shock the heart. Like I was talking about with the way the heart works, we try to shock it, get it back into where, essentially stun it so that it starts to beat like it's supposed to. This is also something that, we are shocking you. We're actually now starting to do this where we're doing compressions as we're shocking. I scared all the nurses that I was working with one night when I said, okay, go ahead and shock. I'm going to continue the CPR because it's not too much of a shock, but I've seen one patient catch on fire from this type of stuff, so it is something that has, a downside to it as well. This is also something if done early can help you with survival.